All right. Good afternoon, everybody, and good morning to those who are joining us from outside Nigeria in the US or elsewhere. Thank you so much for joining us, our lecture series. This is the first one we're doing, titled ECG, 12 lead ECG assessments. It's a basic introduction for healthcare providers. So I'll hand over now to our leadership and development coordinator, Mr. Olumide Obe, to do a short introduction, and we would go on to Professor Akintade, the lecturer for this series. So thank you, everyone.
All right, good afternoon, everyone. I welcome you all to the maiden edition of our Ed for Nigeria lecture series. So my name is Olumide Obe. So I'm the leadership and development consultant for Ed for Nigeria. So basically, the aim of this program is to help the healthcare professionals, the healthcare workers, and the ones in training to build the skills and help them in developing a good standard so as to bring about giving better treatment to Nigerians as a whole. And that's why we have Health for Nigeria. So when we educate ourselves, it's in the other side, it helps as much as possible to, when we educate ourselves, in the long run, it helps in turning around and boosting the healthcare system, helping to treat patients in a wrong way. Sorry, pardon me for that. I'm not. So now, to start with, I would like to introduce the officials and the executives of the NGO, which is Health for Nigeria. So permit me to start by introducing the founder and the chief executive officer, and that is Professor Abimbola Akintade, an alumnus of the University of Maryland, a professor. And to also point to you, is also, I don't want to say a political appointee, but he's the Commissioner for Health for the Maryland state in the United States of America. So, and also I'd like to introduce the program manager, and that is the person of Mr. Adamovi Osho. He's an alumnus of the Johns Hopkins School of Public Health in the US. Also, we have the likes of Mrs. Tolu Osho, and that is and that is our HR and financial consultant. Miss Karina is a social media consultant and manager, and of course, my humble self. Development consultant. So permit me to introduce or to invite Mr. Adamovi Osho, who will give us a brief introduction about a brief history about Health for Nigeria. So welcome with me, Mr. Osho Adamovi, the program manager. Thank you.
All right, thank you so much, Olumide, for that introduction. And I'll just really briefly talk about Health for Nigeria, how we got to where we are today and where we started from. So as Olumide mentioned earlier, Dr. Akintade is our founder and the visionary behind this organization. He started the process of founding Health for Nigeria in 2019, but we didn't really get our foot on the ground until the beginning of 2020. Where we envisioned what we would like to do here in Nigeria, basically provide affordable and accessible healthcare to all Nigerians. And since then we've been able to expand our programs now to include this nursing school program, which this lecture series is running off of. And we're currently working in 5 different schools in 3 states, reaching up to about 4,000 students at the moment, providing healthcare services for them. With school health clubs at each of these schools, as well as a functioning sick bay and a school nurse that is working there. We hope to do a lot more. We hope to expand to as many more schools and states across the country as possible. And we beyond just providing healthcare services, we also have these kind of events that, that are catered towards healthcare providers to kind of improve their understanding of healthcare, increase their capacity, and just assist them, to continue to grow their skills and further their continued education. So that's a very, very short introduction to Health for Nigeria. But I think for sake of our time, I'll allow us head over now to Professor Akintade, who will take us through the lecture for today. So thank you all so much and enjoy. Professor Akintade, thank you.
So thank you very much, Mr. Ocho. Good afternoon, everyone. And for those who are in different geographic locations, it's probably morning where you are. So good morning, good afternoon. I'm going to share my screen, so just give me 1 second. So can you see my screen now? Are you able to see my screen?
Yes, sir.
Okay, wonderful. So as I've been introduced earlier, my name is Professor Bimbala Akintade. Close friends and family call me Bim, which is acceptable. And I'm the Associate Dean of the Master's Program at University of Maryland in Baltimore. It's a privilege for me to actually have this opportunity to give this presentation here. Cardiac topics are near and dear to my heart. Health for Nigeria was founded based on my personal experience with the healthcare sector in Nigeria. My mom passed away from a heart attack. So I think that sort of subconsciously moved me into this direction in terms of my love for the cardiac system. So before I start with this presentation, usually I try to talk to my audience about why I feel that I am capable of, or I'm the right person to give a certain topic. So I've been a provider now for about 16 years, and my first job was at MedStar Washington Hospital Center in Washington, D.C. in the U.S., where I was responsible for managing patients in the surgical ICU. Those units include the trauma ICU, the neurosurgical ICU, general surgical ICU, surgical IMCU, and my favorite, the cardiac surgery ICU. So in the cardiac surgery ICU, we managed patients after cardiac surgery. So coronary artery bypass, grafts, valvular replacement or repair, or ventricular assist devices. And those patients required EKGs before and immediately after their surgical procedures. So without exaggeration, I've probably reviewed thousands and thousands of EKGs. So that's part of where my experience comes from. In addition to that, I've taught this lecture the basic ECG interpretation and also the advanced ECG interpretation to both master's and doctoral level students here in the US. So that's just a background. Whenever I start presentations, I like to start with a case study, just so it's not just theoretical information, but we can actually apply it to some real life situations. So this is just a very quick and dirty chest pain scenario. So a 45-year-old female with a history of hypertension and diabetes presents to a public health center with severe chest pain unrelieved by rest, shortness of breath, and diaphoresis. Many of us know that patients that present with chest pain, automatically it's an MI, a myocardial infarction, or for the more layman's terms, it's a heart attack until proven otherwise. So what do? We start them on our acronym MONA, right? So morphine, plus minus oxygen. So the current guidelines are now starting to move away from just placing everyone on oxygen because of the potential for oxygen toxicity, so plus minus oxygen, nitrates, and aspirin. The other thing we'll do is we will get cardiac enzymes, which are very sensitive and specific. And the third thing is to get a 12-lead EKG. So this is what we get back from the EKG. So what are your thoughts? So looking at this EKG, even without any additional knowledge, it looks abnormal. So the abnormality is what we will be covering today, okay? And as we go along, I've built in opportunities to stop, take a breath, and answer questions. But as we go along, if you have a question, concern, please feel free to ask. And hopefully we'll get done with enough time to actually have a little bit of discussion if there are discussion points to be covered. So I recognize that not everyone in their practice interacts with EKGs, but I think just having the basic understanding is very important. This is one of those things that most people probably wouldn't get on the first pass, but for those who are interested in getting a certificate of attendance at the end of this presentation, please reach out to Mr. Olumide Obe or Mr. Adamove Osho, and they would make the materials available to you. And that way you can review the materials, go over some sample questions also. So my objectives for today, which is important, just so you know what we're going to cover, include some basic anatomy. We'll also talk about the coronary arteries. We'll talk about derivation and electrical views of the standard, augmented, and precordial leads of the heart, measurements and waveform interpretation. We'll talk about the QRS axis. For more fun stuff, we'll get into rhythm analysis. Usually I don't just jump directly into rhythm analysis. I try to build a foundation first. So once we have the foundation, then we can make it as complicated as possible, but we always have a baseline to go back to. So in the rhythm analysis, we'll cover normal sinus rhythm, myocardial ischemia, injury, infarction. We'll talk about atrioventricular blocks, atrial enlargement, and ventricular hypertrophy. And once again, for those who are interested in getting a certificate of attendance from this workshop presentation, you'll get additional practice ECGs sent to you. Okay, so just a quick introduction. For example, like the case study of the patient that presents to the PHCs, you can't see the heart directly, so then how do we evaluate the heart? So an EKG provides recorded electrical voltage of heart cells. And this should be a review for any of you who have taken biology. Some characteristics of cardiac muscle cells include automaticity by way of intercalated discs. So the heart cells are very excitable. If they're excitable, they generate some form, or they dissipate electricity. And anything that dissipates electricity can be measured by a voltmeter. So just think about the ECG as your one-dimensional measure of the heart's function or operation. So basically, ECGs also provide an introduction into the orientation of the heart in terms of the flow of excitation of electrical current. It helps us with conduction disturbances, mostly, electrical effects of medications and electrolytes. Also, we can get information regarding cardiac muscle mass from ECGs, and most importantly, about 95 to maybe 98% of the reason why we get an EKG on a patient is to rule in or rule out ischemia or infarction. And in layman's terms, that's to rule in or rule out a heart attack, okay? All right, so for any of us who have ever picked up an EKG and looked at it, depending on the machine that conducts the EKG, if you look on top of it, it actually tells you what the rhythm says. So if the EKG machine provides a printout, then why bother learning how to interpret an EKG? So the reason, in my opinion, is just like, how many of us know how to interpret an arterial blood gas or read a chest X-ray? And you can actually type it into the chat box. So interpretation of EKGs are just like arterial blood gases. Imagine if you were to get an arterial blood gas on a patient, and without getting further information about the pH, the PaO2, the PCO2 or bicarb, the printout just tells you metabolic acidosis. or respiratory alkalosis without giving you a measure of significance, it's really difficult to understand how bad it is. So for example, for those who have looked at 12 lead EKGs, a very common readout from an EKG could read non-specific T-wave abnormalities. Consider lateral wall ischemia. What exactly do you do with that? You know, so as much as getting the information from the computer is helpful, I think for us providers, it's still important to be able to pick up an EKG and make your own interpretation. All right, so this is your trivia question for the day. And it's not a trick question. What's the difference between an ECG and an EKG? And I want this to be as interactive as possible. So if you know the answer or you want to take a guess, you can actually just type it in the chat box. And I'm actually trying to find access to the chat box. I can't see it while I'm sharing my screen, unfortunately.
We will keep track of it and let you know if any chats come in.
Oh,
I think
okay.
we can also maybe allow people to raise their hands if they know how to use the raise hand function. If you need to ask any questions or you want to respond to anything as well.
Okay, wonderful. So are there any takers for the difference between an ECG and an EKG? Any chats, any text in the chat box, Mr. Osho?
Nothing so far, sir.
All right. All right, so what I learned in my doctoral program, right, is regardless of all the science in the world, the first thing you do when you're conducting research is you Google information. So Google actually might, even if it doesn't give you the right answer, I think it might streamline your research a little bit. So this is a bit of a trick question. There's no difference between ECG and EKG. They're technically the same. So Sir Willem Einthoven, he was a Dutchman, and in 1924, he received the Nobel Prize for Science for coming up with the first string galvanometer, which was the first EKG machine in the world. And I believe in Dutch, electrocardiogram is spelled with a K. So that's how we actually came up with EKG. And as you know, the English pretty much have taken, took over everything probably back in the 20s. And so the English spelling was with a C instead of a K. So I'm sure even in this presentation, you would hear me alternate between ECG and EKG, but technically they're the same. But I thought that was interesting to know. So anyway, ECG, EKG, both of them are the same. So now let's talk a little bit about the electricity of the heart. Earlier, I mentioned characteristics of cardiac muscle cells, right? So ECGs or EKGs, they record or measure electrical activity of the heart. And for those of you who have taken biology, some of this should be a mild review. This is generated by changes in electrical charges outside the cell walls, causing shifts in positive and negative electrolytes. So even though it's called a 12 lead EKG or ECG, there are only 10 electrodes. So it doesn't mean each electrode is, a view. Basically, ECGs work based on complex mathematics and physics using vectors, finally, I'm actually now able to see some of the chat. So it seems like some of you were actually totally on top of it. So thanks for playing along. So ECGs provide 12 views, basically 12 different cameras of the heart. And that's just being able to see the heart from 12 different vantage points. That's what 12 lead comes from. So just some quick verbiage that I'm going to use as I continue to speak about 12 lead ECGs. So cells at rest are considered polarized, which means they're negative. So inside of the cell is more negative than the outside, right? So at rest, cardiac cells are polarized. When cells are stimulated electrically, they depolarize and they contract. So when I talk about ventricular depolarization or atrial depolarization, that means atrial contraction or ventricular contraction. And the process by which cells return to their resting potential is called repolarization, okay? All right, so for those of you who like cardiac like myself, a picture like this just makes me smile. So very quick orientation to the coronary arteries, right? Many of us hear coronaries, coronary arteries, but we never really make much sense of it. So we have two main coronary arteries. We have the right coronary artery and we have the left main coronary artery. So the right coronary artery pretty much originates in the inferior aspect of the heart and it goes posteriorly to the heart. The left main coronary artery bifurcates, right, into the left circumflex artery, which also then goes sort of laterally and posteriorly, while the left anterior descending perfuses the anterior aspect of the heart. So why is this important? If you don't remember anything from this presentation, this slide is the take-home message, basically. So how do the coronary arteries translate into an ECG? So once again, this is basically the meat of this presentation. So imagine taking a 12-lead EKG and wrapping it around the heart and correlating different aspects of the 12-lead EKG with the heart. Like that's what you want to take away from reading a 12-lead EKG, not just to see something on paper, but to be able to interpret it and also identify the coronary artery that's responsible and also the territory of the heart that's affected. Okay, so I'll give you an example. We just talked about the right coronary artery. The territory that the right coronary artery perfuses is the inferior aspect of the heart. And the leads on the EKG that are demonstrated by a disturbance in the right coronary artery would be leads 2, 3, and AVF. Some of you have probably heard the term 2 or more contiguous leads. So imagine you can have an ST elevation or ST depression in only lead 3. What do you do with that? You really can't do much with it. For anything on an EKG to be significant, it has to occur in 2 or more contiguous leads. And what that means is it has to occur in 2 or more of these leads that correlate to a specific coronary artery. So for example, if you have ST elevation in leads 2, 3, and AVF, we would interpret that as right coronary or an inferior wall ST elevation. And the coronary artery responsible is the right coronary artery. So if you think about it that way, when you look at the EKG, you look at the leads that are responsible, 2, 3, AVF. We understand that the territory is inferior and the coronary artery responsible is the right coronary artery. The same thing for the LAD, right? The left anterior descending. The territory it perfuses is the anterior aspect of the heart, and it's represented on the 12-lead EKG by V2, V3, and V4. The left circumflex, remember the left main bifurcates into the LAD, anterior left circumflex, around lateral. That perfuses the lateral aspect of the heart, and on a 12-lead EKG, that's seen as 1, AVL, V5, and V6. The septal wall has some overlap between the RCA and the LAD. So they both come together to perfuse the septum. And that is seen mostly in V1, but on some EKGs, it's seen in V1 and V2. So memorize this, 2, 3 AVF. The way I usually try to remember this is 2, 3 AVF, the F in there reminds me of inferior. 1 AVL, 5 and 6, the L in there reminds me of lateral. And then the interior leads, once we go over lead placements, that would make more sense because the interior leads are like placed on the interior aspect of the chest. So if you think about it that way, it should make sense. So for those of you biology ethicos out there, in patients with inferior wall MIs, what is the greatest concern and why? So if you could correlate a very important anatomic structure in the inferior aspect of the heart, why would we be worried about that? So the RCA perfuses the Cyanoatrial Node, and the SA node is the pacemaker of the heart. So if there's a significant RCA lesion, the SA node is not perfused, and we would have significant heart rate issues. So just looking at an EKG, you can actually work your way back from the leads to the territory and also to the coronary artery, okay? All right, so another quick review of the cardiac conduction system. So once again, slides like this excite me. So the wave of excitation, I just talked about the cyanoatrial node, and you can actually see it right here. If you remember that picture of the coronary arteries, we established that the RCA originates on the right side. So you can see that the SA node is actually embedded in the wall of the right atrium. So the RCA perfuses the SA node. So if there's an issue with the RCA, we would have issues with heart rate. So the wave of excitation originates in the SA node. And when that happens, both atria depolarize simultaneously. So remember, a characteristic of cardiac muscle cells is automaticity. If you excite one cell, it happens in a split second. It excites all the other cells around it. And basically the electrical conduction hops from these intercalated discs from one cell to the next, okay? So once the atria depolarize, there's a very brief delay, right? And what that delay helps us with is with ventricular filling. So we don't think about it, we just think about the heart beating as one, but technically that's not true. The atria contract first, it dumps blood from the atrium into the ventricles, and then the ventricles contract. So imagine if the whole heart beat at once, blood is not going to flow. So atria contract first, but it happens so quickly, the blood empties from the atria into the ventricles, then the ventricles contract, right? And expels blood from the heart. So after the atria contract, right, the wave of excitation hits the AV node, which dissipates the electrical conduction into the ventricles. And it does this by way of bundle branches. So there's a right bundle branch that goes all the way through the right ventricle. There's also a left bundle. The left bundle actually bifurcates into two. So there's a left posterior fascicle and there's a left anterior fascicle. And the reason why we need two fascicles on the left versus the right is, if you think about it, the right ventricle pumps blood to where? To the pulmonary system. It's a low pressure system, so you don't actually need that much pressure on the right side. The left side of the heart, on the other hand, pumps blood to the rest of the body, right? So it's a thicker, it's a stronger chamber, and just based on its muscle mass, it requires actually two fascicles to dissipate the electrical conduction throughout the left ventricle. And it does this by way of the Purkinje fibers, okay? So hopefully that was a review for some of us. Speaking about lead placement, for any of us that actually handle 12 lead EKGs, I know most providers just order it. They don't necessarily, or they're not necessarily involved in the actual obtaining of the 12 lead EKG. It's still important to understand exactly how it's done. Just so if there's an issue with it, we can make recommendations to those who are obtaining it. So once again, 12 leads means 12 different pictures, 12 vantage points. It doesn't mean 12 wires. Remember, there are only 10 electrodes that connect to a patient. Good skin contact is essential, right? Because we're measuring electrical conduction through the skin. So if we don't have good skin contact, there might be some artifacts on the EKG. One electrode goes to each limb. We have 4 limbs, right? And the other 6 go around the chest. So electrodes labeled left arm, left leg, right leg go to the 4 limbs, and then the chest leads are usually labeled V1 to V6. All right. And this is just a picture demonstrating that. So V1, V2, V3, V4, V5, V6. So when I was talking about lateral or, the anterior leads earlier, you can see sort of where they correlate on the patient. So that can sort of cue you in to exactly where the infarct might be and to what blood vessel you correlate that with, okay? This is just additional information in terms of the orientation of the 12 leads. So we have 3 different types of leads. We have the bipolar limb leads, augmented unipolar limb leads, and the unipolar chest leads. When they're placed on the patient, leads 1, 2, and 3 go from the right arm to the left leg. For lead 3, it goes from the left arm to the left foot, right? The augmented vector right, augmented vector left, and the augmented vector foot, these complete the frontal plane. For the chest leads, these are the horizontal planes, right? Just based on that last picture I showed. Once again, they're V1, V2, V3. These are posterior, anterior, V4, V5, V6. These are lateral, okay? And this is just a graphic talking about how important it is to get proper skin contact. If you're an ID person here, you would probably disagree with shaving patients to get an EKG. To a certain extent, I would agree with that, because when you shave patients, you could actually nick the skin and introduce infection that way. But most importantly, if it's a matter of life and death and you need an EKG and you need good skin contact, you can always treat an infection. But, heart cells don't regenerate, so if you have to shave a patient, shave the patient. So just like chest x-ray interpretation, ABG interpretation, 12 lead interpretation requires a certain method. If you don't have a method, a stepwise method in terms of how you interpret these things, odds are you're going to make a mistake or you're going to leave something out. So it doesn't matter what method you use, but just make sure you have a method. So just looking through the literature, I came up with 2 different methods. So there's the 6-step method, which means the first thing you do is identify the rate and rhythm, your axis determination, intervals, your morphology of your waveform, ST elevation, whether real or mimics, and then try to identify ischemia, injury, and infarct. Another method could be measurements first, rhythm analysis, conduction analysis, waveform description, and then you interpret the EKG. The most important thing on this slide is comparison with the previous ECG, if that's available. Whenever we read a 12-lead EKG, from our vantage point, everything we see on the EKG is active, it's acute, it's happening right now. But sometimes if you look at a patient's history, if they have a previous EKG and you compare the 2, say an EKG from 4 years ago, they could have, some waveform abnormality that was present 4 years ago. Well, if it was there then it's not acute. It's not something I'm going to worry about now. The goal is trying to see if there are any changes, and whatever those changes are, become my priority, okay? A lot of times patients won't have a previous EKG, then you treat the current EKG as your only source of information. But if they do, it's very important for you to actually do that. All right, so now we're going to go to the waveforms, which I think is fun. So the flat line, this is the isoelectric line, right? So think about it, we're equating electrical conduction in the heart to a piece of paper. So if you're looking on the 12-lead EKG, the isoelectric line is a flat line. It means there's no electrical conduction taking place, okay? The P wave, so that's the first the first depolarization you see on an EKG. This is the sequential activation of the left and right atria. So remember, based on how quickly cardiac muscle cells work, even though the SA node is on the right side, both the right and left atrium depolarize at the exact same time, okay, in a normal heart. The Qrs complex. This is when the right and the left ventricles depolarize also simultaneously. This is demonstrated on an EKG with a Q wave, which may or may not be present. Typically, it's a negative deflection on the isoelectric line. The R wave is the first upward deflection following the P wave, and then the S wave is the downward deflection following the R wave. And I'll show you a slide that shows all of this shortly. So the ST wave just represents, once again, ventricular repolarization. So if you look at this, then you'll say, where is the atrial depolarization? So remember, depolarization is contraction, right? So the atria contracts, and while the atria is relaxing, the blood has now dumped into the ventricles, and the ventricles are contracting. So they contract, they relax, they contract, they relax. But on the 12-lead EKG, you see the QRS, which represent ventricular depolarization, and you also then see the T wave, which represents ventricular repolarization, but you never see atrial repolarization. That's because the atrial repolarization occurs in the middle of ventricular depolarization. So it's not evident on the EKG, okay? So the PR interval is the time interval from onset of the atrial depolarization to the onset of the ventricular depolarization. The QRS duration is how long it takes for the left ventricle to contract. The QT interval is the duration of the ventricular contraction and relaxation, right? So ventricular depolarization and repolarization. The R to R interval. So remember, the R is the first upward deflection. So the R to R interval is the duration between each ventricular cycle. So if you look at a 12-lead EKG, you would see the upward deflections, and if you should count each and every one of those, they should be evenly spaced, which means the heart is contracting in a normal rhythm, okay? This also gives you the ventricular rate, which most of the time, that's what we take as our heart rate. And we take that as our heart rate because there should be a P wave in front of every QRS, which means your atria contract right before your ventricular contraction. So either one you use in a normal heartbeat should be fine in terms of estimating ventricular rate. And the P to P interval, just like the R to R, this is the duration of the atrial cycle. So it also indicates atrial rate, all right? So everything I just said is depicted here in this picture. So this is the isoelectric line. There's no electrical conduction occurring. Atrial depolarization, back to the isoelectric line. So this is your atrial contraction, back to the isoelectric line. So P wave, isoelectric line. The R is your negative deflection. Oh, sorry, your Q is the negative deflection, and the R is the upward deflection. So just to talk about the Q wave real quick. Q waves also represent prior injury, and we'll talk about that as we go along, but a normal Q wave has to be less than a third of the height of the R wave. So if you see a Q wave on an EKG, it could be normal as long as it's less than a third of the height of the R wave. So in this case, if you were to just visually estimate the height of this R wave, the Q wave is definitely less than a third. So this is normal, right? So Q is the first negative deflection, R is the positive, the S is coming down. We're back to the isoelectric line, and the T wave is the ventricular repolarization, okay? I know this seems like a lot of information, but this is kind of what you have to know before you attempt to interpret a 12-lead EKG, because a lot of times this is a matter of life and death for many patients, okay? All right, now to quickly orient you to, so this is the first time we're actually going to look at a rhythm strip with a rhythm on top of it. Each small box, so remember, this is electrical conduction, and we're going to translate this to the actual heart. Each small box is 0.04 seconds, okay? Typically in a 12-lead EKG, you would have solid lines, right? In between each solid line are 5 small boxes. So 5 small boxes, if you calculate 0.04 times 5, that's 0.20 seconds. So the more you actually look at EKGs, the more you can get a better orientation, to what the strip looks like. So now we're going to talk about normal intervals. So the PR interval, if you remember, that's the beginning of the atrial depolarization right before the P, all the way to the ventricular depolarization. So the distance between the P all the way to the Q, that's the PR interval. And this, the norm should be 0.12 to 0.20. So if you're calculating by boxes, that should be no more than 3 to 5 boxes, all right? The QRS complex, remember that's the ventricular depolarization, that should be no more than 0.08 to 0.10, depending on the reference you use, it's 0.08 to 0.12. So if you're calculating by boxes, it should be no more than 2 to 3 boxes total. The QT interval, right? So that's from the Q all the way to the T here should be about 450 milliseconds or 460 milliseconds in women. So this varies based on sex, heart rate, and it's typically half the distance of the R to R on a normal heart rate, okay? With this, typically you don't have to calculate this because the EKG would tell you what that is, but it's still nice to know what the norm is for males and females. All right, so some of the tricks that you can use by just sort of visually trying to estimate a heart rate. Most machines will give you a heart rate printout or just tell you what a patient's heart rate is by looking. But at the same time, once again, it's very important to also be able to determine this by looking at either a 12-lead EKG or a 6-second rhythm strip. Right. So usually if you're in the ICU or the emergency room, most patients are hooked up to a monitor. And if you look at that monitor, that rhythm strip, you can calculate or estimate the heart rate. So I mentioned earlier, so if you look at the top picture, these solid pink lines going up and down, in between that are 5 small boxes. So in between those solid lines is 0.20. So now we're oriented, to the rhythm strip. So it's 0.20 seconds between 2 of the large lines. If you count the number of QRS complexes in between 30 large boxes, so this is a 6-second strip. I'm sure many of you have learned how to estimate heart rate by just, checking your own pulse. If you check your pulse for 10 seconds, you multiply by 6 to get your heart rate, right? If you check it for 15 seconds, you multiply by 4 to get your heart rate. And it's rate per minute. If you, check your pulse for 20 seconds, you multiply by 3. It's the same basic principle here. So for a 6-second strip, you multiply by 10, right? And for the 12-lead EKG, typically at the bottom, it gives you a rhythm strip, and that's usually either leads 2 or V1, same thing. But since that is a 10-second strip, you multiply by 6. You could either do that, or this bottom strip is from a code machine. So I don't know how many of you have been involved in cardiopulmonary resuscitation. Not because I want to, but because I've worked in the ICU for my entire career. I have run very many codes. And when I say code, it means someone died and you have to revive them. So the rhythm strip at the bottom is a printout from a code. And basically, if you look at the 2 solid lines, if you were to estimate a heart rate for the 2 solid lines, if that's how fast your heart's beating and your R to R lands on those 2, your heart rate estimate is about 300. If the distance between the R to R is 2 solid lines, it's 150. If it's 3, it's 100. So you can actually just look at the strip and estimate, okay? So this is a 6-second rhythm strip, right? And the way to estimate this heart rate, so this is basically a practice question, is you would count the R to Rs and multiply by 10, right? So it's a 6-second strip. It's what you get in 6 seconds. You multiply by 10 to get a minute. So this is 14. And if you multiply this by 10, that gives you the estimated heart rate for this patient at 140 beats per minute, okay? Now, this is a 12-lead EKG. And if you remember earlier, I mentioned that there's a printout at the bottom. Usually it's either leads 2 or V1, right? And this is a 10-second strip. So here you would count the number of Rs, right? And multiply by 6. So in this case, there are 13. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. You'd multiply that by 6. And this patient's estimated heart rate is 78. Okay. All right. So as you can tell, I'm working my way up, you know, from foundational and principles to actual interpretation. So there's some principles of ECGs that we have to accept. You know, once again, this is pure science. You know, it's pure science, and if you accept these principles, then it makes interpretation more meaningful. So this is based on, once again, anatomy and complex mathematics and physics using vectors. So any of you who've taken physics, I enjoyed physics in school. What's a vector? It's quantity that has magnitude and direction. And vectors are usually depicted as positive arrows. On an EKG, these positive arrows act as cameras, and they record from positive to negative. So remember, we have 3 significant leads here: standard, augmented, and precordial, okay? All right, so whoever can guess where this saying came from gets a free gift. Anyone?
Does that also apply to us at HFN? Because I feel like I know.
Let's give others a try first. No one. All right, Mr. Usher, you can go.
I feel like this is from Despicable Me. Am I?
Yes.
Yeah.
All right. So I know our jobs are very serious, you know, and EKGs are between life and death, but I like cartoons, which is interesting. And this was from I mean, I also have 2 sons and they watch lots of cartoons, but it's funny when kids watch things and they have a different, you know, perception of what's being said. But this specific definition was in a cartoon, you know, so this is basically the definition of vector. And there was someone in the cartoon whose name was Vector. So once again, it's something that has magnitude and direction. All right. All right. So I'm going to talk just very quickly about ventricular depolarization and sort of how we connect that to the electrical axis, looking through cardiac vectors and also using a mean vector, right? Once again, a vector is something that has quantity and has magnitude and direction. So we've established that the wave of excitation originates in the SA node. And once it gets to the AV node, it dissipates between both the left and the right ventricles. But how does this work? So these are labeled 1, 2, 3, and 4. So 1, it actually starts from the intraventricular septum, which is where our AV node is located. And it depolarizes from left to right. And you can see that based on the vector arrows. So this occurs, so looking at 2, it's basically the same direction from left to right, from endocardial to epicardial, which just means from inside out. And the lateral walls are last. So the mean vector, and this is something else that, once again, it's a principle you need to understand. So the left and the right ventricles contract at the same time. If we were to get sort of the mean contraction between the left and the right ventricle, would it be centered? Would it be justified towards the left, or would it be justified towards the right? Can anyone try to take a guess?
Can you repeat the question so I can put it into the chat box?
So the mean vector, so basically the left and the right ventricles contract at the same time. But if we were trying to find sort of like the mean in terms of contractility for both ventricles, do we think it would be justified towards the septum, which would be exactly in the middle of the left and the right? Would it be justified towards the left or towards the right? So I have someone fantastic who says it's towards the left. And that answer is correct, because when I was providing the review of the anatomy, I kind of gave that away earlier. The left ventricle is bulkier because its contraction provides the entire body with blood. So it's bulkier. It has, the bifurcation in the bundles. So this gray, the solid gray arrow would sort of be where the mean vector would be, so more pressure, higher contractility on the left versus the right. That's actually very important. So looking at mean vectors, when the wave of excitation moves towards positive electrodes, it presents as an upward deflection on a 12-lead EKG strip. When the mean vector moves away from a positive electrode, it's negative, right? So it's a negative deflection. A negative deflection is below the isoelectric line. So it's upside down versus upright. And when the mean vector is perpendicular to a positive electrode, it's equiphasic or biphasic. So there's an upward deflection and also a lower deflection. And we'll talk a little more about this when we talk about bundle branch blocks, okay? So we talked about the unipolar chest leads that are placed in specific anatomic locations on the chest wall. Once again, the center of the heart is considered the theoretical negative. When I talked about anterior and lateral leads, this is what they would look like. So V1, V2, V3, all the way to V6, okay? In terms of lead placement, once again, many of us will probably never be the ones to obtain a 12-lead EKG. It's still important for us to understand exactly how we obtain one. So lead V1 is placed under the fourth intercostal space on the right sternum. You have to count down from the sternum, 1, 2, 3, 4. Lead V2 is placed on the opposite side, right? Fourth intercostal space on the left. Lead V4 is placed over the fifth intercostal space, mid-clavicular line. Lead V3 is placed midway in between leads V2 and 4 intentionally. Lead V5 is placed on the same horizontal axis, but more anterior mid-axillary, and lead V6 is placed mid-axillary. So basically, these are vantage points that surround the heart. Once again, the 12 leads are just 12 different camera angles, and these leads help us obtain those. And just some sources for lead placement, which include the American College of Cardiology and the American Heart Association. All right, so I typically talk a little more about axis determination in advanced ECG interpretation. It seems very daunting and very challenging, but it really isn't. It's also very important in terms of trying to identify patients with acute MIs. So there are 3 types of QRS axes, right? Extreme right axis deviation, a right axis deviation, and a pathological left axis deviation, right? Or normal. So if you see an extreme right axis deviation, repeat the EKG. It occurs in probably less than 5% of patients. I think in my entire career, I've probably seen it only once. But if it's true, some of the indications include ventricular rhythm, patients with pacemakers, dextrocardia, or electrolyte derangement. Some of these are quite easy to fix. So the right axis deviation is from 90 degrees to 180. Extreme right is negative 90 to 180. So this could be normal. It could be a left posterior fascicular block, pulmonary disease, right ventricular hypertrophy, etc. Pathological left is from negative 30 degrees to negative 90 degrees. And this is the one we're most concerned with, because this could also indicate that the patient's undergoing an MI, okay? Myocardial infarction or heart attack. So for some of us who think we work too hard work pays off in the long run, but laziness always pays off now. Every time I see this, it makes me laugh. So once again, thinking about axes, the important reason why we look for this is to try to identify acute MIs. And remember, that's one of the reasons why we even check a 12-lead EKG in the first place. So I mentioned earlier that the way the mean vector, right, points a little bit to the left. And the gentleman that got the question right, I have to figure out what gift you get. But looking on this hexaxial reference, the mean vector points down to about 60 degrees. It can vary anywhere from 0 to 90 degrees, right? But, once again, these are based on principles of mathematics and physics. Like they are actually meaningful if you're using this to interpret a 12-lead EKG. So this is basically, what the hexaxial diagram looks like next to what's normal and what's not. So what we're looking for is between 0 and 90 degrees, all right? And even though there's a way to calculate this, once again, that's for advanced. It doesn't necessarily help us in this presentation. If you look on the EKG, it's actually provided. So it's the PRT axis. The R is basically the QRS axis. And for this, it's negative 64. Okay. All right. This is a good time to stop, take a breath, and see if we have any questions or any comments, or if anyone wants to add anything that have said they think I might have missed that might help the group. Any questions? Any thoughts?
All right, so I think we would allow everyone to unmute themselves at this point if anybody has a specific question to ask before we move on. So I don't know, Professor Akintade, maybe like 5 to 3 minutes or so.
No, a couple minutes is
okay,
good. I think there's a hand raised.
Yes, so Ridwanullah Abubakar, sorry, I hope I'm saying that right. You raise your hand. You may unmute yourself and ask your question.
All right, thank you very much, sir. My question goes on. So you mentioned that there is a variation in the QT interval between male and female. I just want to ask, what could be the reason for that?
So I'm going to turn up the volume of my speaker. Can you please ask that question again? I'm sorry, I didn't hear you.
Okay, I said, can you hear me now, sir?
Yes.
Okay, you mentioned earlier that there is a variation in the QT interval between male and female. So I asked, what is the reason for that, sir?
Oh, that's a fantastic question. And basically, just like the reason why there's a variation in BUN and creatinine for male versus female, it's muscle mass. So we take into account that men, I'm sorry, the women who are on here listening, but we basically take into account that men likely have more muscle mass than women. And if you remember, the electrical conduction has to travel through, even though it travels inside the heart through cardiac cells, through the intercalated discs, it's measured at the skin level with the electrodes. So if you take into account the muscle mass, the distance in which it would travel through the muscle makes it a little delayed. But that's a good question. And Oluwakemi is asking if the lecture is recorded. Yes, it's recorded. As I mentioned earlier, for those who are interested in the lecture and who would like a certificate for participation in this presentation / workshop, please reach out to either Mr. Olumide Obe or Mr. Adamovi Osho, and they can get the information to you. All right, I will continue then. All right, so now to some of the...
We have a question from... We have one question in the chat box. It says, usually needs to... Who, I guess it's supposed to be who usually needs to get an EKG? I think that's what they're trying to ask here.
Oh, okay, so that's a very good question. Several different patient populations need EKGs. I think the number one patient population or group of patients that need EKGs are patients who present with any type of either chest pain or a situation that clues a provider into thinking the patient might either be experiencing a myocardial infarction or ischemia. So if you think there's a cardiac presentation, you have to get a 12-lead EKG to make sure you're not missing an MI. There was a time, I'm sure, where we missed these, but this is one of the things that it's so unforgivable for anyone to have a heart attack and not receive adequate treatment early. It's painful because I know our healthcare system is not sort of geared towards the identification and the swift management of these, but the technology is available. So anyone that presents, and typically men present with very classic symptoms, chest pain, either on the left or right side, mostly on the left side. It usually travels down the left arm, up the neck, the jaw. Women typically have atypical symptoms. Sometimes they just feel tired, they're diaphoretic, they're sweaty, they're short of breath, but usually, and especially patients also who have some history of diabetes, history of hypertension, coronary artery disease, any of these patient populations, you need a 12-lead EKG. For patients who have significant electrolyte imbalances, such as hyperkalemia, hypokalemia, you need to get a 12-lead EKG. For patients who are in significant or severe sinus tachycardia, just significantly increased heart rate, patients in atrial fibrillation, just any either cardiac anatomical issue or electrical conduction issues, those patients should get a 12-lead EKG. And trust me, you can't get enough of these. There's certain patient populations where we just leave the machine hooked up to them and we just get multiple EKGs. Also, for patients who are undergoing cardiac stress tests to identify if they have blockages with coronary artery disease, they receive multiple 12-lead EKGs too. I hope that answers your question.
So there was a follow-up question saying, asking if the EKG is enough to detect heart problems. And I think the ending part of your previous statement answered the question after that, asking how often can a patient undergo EKGs? And you just mentioned sometimes you leave patients hooked up to it continuously if need be. But the question before that was, is the EKG enough to detect heart problems? Okay,
so the EKG, to a certain extent, yes, it's enough to detect, but you would not necessarily treat a patient based only on an EKG. You need to get additional information like patient history and also, some additional lab tests. Prior to surgery, most surgeons would ask for a workup, and that workup would also include an EKG. And trust me, I've seen many patients who are healthy, no symptoms whatsoever. They need a dental procedure done. We check an EKG and we find something under EKG, and that now starts their cardiac journey, but you can get an EKG for several different reasons. And once again, how often do you get one? you don't get an EKG typically on just your annual evaluations, you know, but once again, like I mentioned, before surgery, if you have a cardiac issue or patients who are admitted in the hospital who have electrolyte imbalances, you know, or just sometimes a clinician, you know, could decide based on presentation or, you know, based on how the patient is doing to get a follow-up EKG. I mean, that's acceptable. Okay. All right, so now we can start talking about rhythm analysis, you know, which is to a certain extent the fun part. So after you understand all those principles, now you can pick up an EKG and basically read it, you know. So once again, I'm sure some of you are like, I didn't realize this much goes into an EKG, but you know, that's basically how it works. So normal sinus rhythm is where all of us aspire to be. You know, this is normal anatomic or normal physiologic and electric conduction of the heart. All right. In the past, when someone asked me, you know, what's normal sinus rhythm, I would always say it's a P wave followed by a Qrs complex. But, you know, at this level, there's actually more to it. So normal sinus rhythm is an upright identical P wave before each QRS complex with regular R to Rs. So to have regular R to Rs, it means one, the heart rate is regular and there's a P wave in front of each QRS complex. So sinus tachycardia is heart rate greater than 100. Sinus bradycardia is heart rate lower than 60. So characteristics of normal sinus rhythm, heart rate of 60 to 100. The rhythm is regular, once again, P wave before each QRS, evenly spaced. PR interval 0.12 to 0.20, and QRS, if you remember those interval calculations, QRS less than 0.12. So this is what we want. So now we're going to talk about the ST segment, right? And if you take a look at this, we're all oriented to the boxes. We know what the atrial depolarization is. We know what the QRS is. We know what the isoelectric line is, and we know what the T wave is, right? So the ST segment is this shaded segment right here, right? So it's normally isoelectric. The ST segment is normally isoelectric. It's flat. Nothing should be happening. That's neither elevated nor depressed, okay? And this is what it would look like on your EKG. It's flat, all right? So it's probably the most important element to identify on EKG when you're looking for evidence of a heart attack, all right? So that's what we look for. And I'm sure some of us have heard ST elevation, inferior wall ST elevation, you know, like this is the meaning of that elevation, okay? So I'm going to talk a little bit about the 3 I's, and that's ischemia, injury, and infarction, okay? So ischemia, for some of us who have taken biology or who remember cell biology, is the lack of oxygenation to a muscle cell, right? And if it's a cardiac muscle cell, this is demonstrated on EKG by ST, either ST depression or ST wave inversion. So this is an incomplete blockage of one of the coronary arteries, but it's occluded enough to the point where some of the cardiac cells are not receiving enough oxygen, all right? Injury occurs when there's prolonged ischemia without revascularization, you know, without that being open so the blood can continue to flow and everything, you know, all the cells around that coronary artery becomes properly perfused. So injury is another thing we look for, and this is demonstrated by ST elevation on EKG. So if you look at this diagram, you can see the ST, you know, significantly high. And this is, you know, basically what we look for on a 12-lead EKG. And an infarct just means the tissue's dead. You know, and so this is the progression. It starts from ischemia, it leads to injury, and then basically tissue death. At that point, I mean, it's not, you know, we can't revascularize it. And this may or may not produce a Q wave on EKG. So myocardial ischemia causes ST segment depression with or without T wave inversion. That's for the zone of ischemia. For the zone of injury, we see ST segment elevation with or without loss of an R wave. And myocardial infarction causes deep Q waves. So what's interesting is I talked about some patients who might need a surgical procedure. They're healthy, they've never felt better, they have no history. They come in, they get an EKG, and they find Q waves on their EKG, which means at some point in their life, they had a heart attack, but it was mild enough. It was probably a small coronary artery that didn't necessarily produce any significant symptoms, but it will forever be recorded on their EKG. You know, so we end up being the ones telling them that, you know, at some point in your life, you had, you know, a coronary event. So just to orient you very quickly, this is the septum, a left ventricular cavity, and this is our epicardial coronary artery. So when the coronary artery is well perfused, this is what it looks like. So on a positive electrode, we have atrial depolarization, ventricular depolarization demonstrated by a positive P wave, a positive reflection on our QRS, and a T wave. So in patients who are ischemic, they have an inadequate oxygen to tissues. It's represented by ST depression or T wave inversion, may or may not result in infarct. If they're reperfused, if we can, you know, reverse whatever pathology is causing the ischemia, we can get them reperfused. All right. So this is what ischemia would look like. This is a lesion, some sort of blockage. All right. And if you look at this diagram, those black dots is starting to represent areas of hypoperfusion. So this is what ischemia would look like on a 12-lead EKG, right? So T wave inversion, right? Lead V2, V3, V4, V6, V5, right? So anterolateral, right? If you remember that table I presented earlier. So now you can start to look at the EKG and you can start to correlate it to not only the body, but also to the coronary artery that's responsible, all right? Once it comes to injury, that's prolonged ischemia, that's transmural through the cardiac muscle wall, is represented by ST elevation. And this usually results in infarct, especially if the patients are not revascularized. So this is a thrombus, that's a lesion. Once again, there's a blockage, and this is what it looks like. Ischemia, if you look on your Qrs complex, there's an ST elevation. Remember that ST should be isoelectric. It should be all the way down. Once it's elevated like this, then we know there's ischemia present. All right, that's led to injury. So if you look at this EKG, you should be able to identify exactly what leads have injury, demonstrated by ST elevation. Okay, and if you remember back to that slide, looking at contiguous leads, if you remember I mentioned it has to be in 2 or more contiguous leads. Here it's 2, 3, and AVF. Using my primary school cheat mode, F reminds me of inferior, so this is an inferior wall ST elevation MI. Okay, and if you think back to that slide once again, the inferior wall, so 2, 3, and AVF perfuses the inferior wall. If you trace it back to the coronary artery, that's the right coronary artery. So you know exactly what coronary artery is responsible. And if it's the right coronary artery, now what are we worried about? We're worried about heart rate issues. And if you look at this EKG, the patient's heart rate is 57. So everything is basically related. Okay, in this patient, I would have a pacemaker close by, right? You know, a temporary pacer, because I'm worried that if this progresses, the patient is going to lose their SA node because there's no perfusion to the SA node, that heart rate might continue to decrease. All right, in terms of infarct, that's death of tissue. This is represented once again, as I mentioned, by Q waves on an EKG. And what's actually interesting about infarcts and Q waves is that not all patients who have had MIs develop Q waves on their EKG. I think most patients do, but not all patients. So don't be surprised after a positive MI on a patient that you get a post perfusion EKG and you don't see Q waves. So it doesn't happen in all patients, but when you see Q waves present, it's indicative that that patient has had an MI, all right? And this is basically what it looks like. I mean, that's tissue death. And if you look at the Q wave here, it's more than a third of the height of the R wave. And that's what gives us a positive Q wave, okay? So if we look at this EKG, 2-3 and AVF, it could be actually that same patient, right? So if you look at 2-3 and AVF, the deflection on the R wave should be higher and the Q wave should be less than a third of the height of the R wave. But here it's mostly Q with a just very tiny little R. So this patient definitely had an MI, okay? And we can tell by this that it was an inferior wall MI that affected the inferior aspect of the heart, and the lesion or the coronary artery responsible was the RCA, okay? So an evolvent MI just means over time. So if you were to follow a patient who had an obstruction, or from 0 to weeks later, this is what it would look like. So once it starts, once the occlusion starts, there's a pronounced T wave, elevation usually, and typically it's convex, right? From 1 to 24 hours, the patient demonstrates depressed R wave and pronounced T waves. They have pathological Q waves that may happen or may not happen. Day 1 to 2, there's an exaggeration of the T wave. So this is our significant ST elevation. So days later, as you can see, the ST wave starts to come back down towards the isoelectric line. And weeks later, the ST is all the way back to the isoelectric line, but now the patient has a Q wave. And so when we look at the EKG afterwards, we can tell that the patient has had an MI at some point, okay? So summary of ST elevation, a normal ECG does not rule out ACS. And this is the other thing. Remember, this is based on mathematics and physics principles with some anatomy included. The patient could have a non-ST elevation MI, which just means they're having a heart attack, but it's not captured on the EKG. And they could have positive cardiac enzymes and positive symptoms. We would still treat that, okay? ST segment depression represents ischemia or possible infarct, right? ST segment elevation is an evidence of an acute MI. You see ST elevation MI on an EKG, that's a life-threatening event. We have to treat the patient, all right? And Q waves may or may not follow ST elevation or depression, okay? All right, this is another good time to stop, take a breath, and answer some questions about ST elevations and MIs. Any questions?
I don't see anything in the chat, but if anybody wants to raise their hand or speak, you may go ahead.
I know it's a lot. I just don't want to seem like I'm talking at you the whole time. So I welcome your comments. And yes.
Okay, we have one question again. Mr. Abubakar, you may go ahead.
Okay, sir. Thank you. Just now you mentioned that the normal ECG does not rule out HFN. So I want to ask, is it then possible that we have a normal ECG, but maybe due to the test from cardiac enzymes, we have a result that is suggestive of myocardial infarction? So is it possible that the cardiac enzyme is telling us there is an infarct somewhere, but on the ECG, nothing is shown from the result?
That is absolutely correct. And that would be termed a non-ST elevation MI, which means on the EKG, there's no ST elevation, but the patient is still experiencing an MI. And the way we would be able to determine this is because cardiac enzymes typically are CK and troponins are very sensitive and very specific for MIs. So those can be positive. The goal of the EKG is complementary, but also the EKG can clue us into the specific coronary artery that's responsible. So when we have a non-ST elevation MI, unfortunately, we don't have additional information, but we know that the patient is undergoing an MI. So we would treat that. So if you have positive cardiac enzymes, CK troponins, and the patient is symptomatic, we would accept that as a non-ST elevation MI, or we would diagnose, not accept, we would diagnose that as a non-ST elevation MI.
Okay. So, sir, is there any reason for the non-ST elevation MI? Any particular reason why the ST is not going to be elevated in the patient? And the result of the cardiac enzyme is suggestive of cardiac enzyme.
So that's another good question. If you remember when I showed the slide of the evolving MI, though cardiac enzymes are sensitive and specific, there's a half-life, there's a long window in which they can stay positive. So technically, even some patients who have an MI might have demonstrated ST elevation and resolved the ST elevation on EKG, but still have positive enzymes. So right. So that could be the cause. The other thing is, if you think about how the cardiac conduction system works, we're using pressure to generate amplitude on a 12-lead EKG. So an MI could be small enough to where the depolarization doesn't change as much, but still provide serum markers, but not necessarily be significant enough to affect the amplitude on the 12-lead ECG. So there are actually several different reasons why we can have a non-ST elevation MI, but the serum markers are very sensitive. I think the troponins are sensitive up to about 98%, and also very specific. So CK is usually cardiac muscle. Troponins, in addition to cardiac muscle, could have some renal implications, but a combination of positive CK and troponins with ST elevation on a 12-lead ECG is automatically an MI. But even in the cases of a non-ST elevation MI, we would still treat. No, thank you. You're asking some really good questions. I appreciate it. All right, now we can talk about blocks. I like this picture because I just got a dog, so it has changed my life. It's like caring for another human being, so you can't go out for too long without coming back home. It's like leaving a child at home. So it's very interesting. It's a topic for another day. Oh, I see Mrs. Ifeoma Babatunde has a hand up. Do you have a question?
Sorry, I touched the error. Sorry.
All right, no problem. All right, so we're going to talk about bundle branch blocks, and this is also one of my favorites. So going back to the quick revision of the anatomy of the heart. So remember, the wave of excitation originates in the SA node. It travels to the atria, they both contract at the same time, travels then to the atrioventricular node to the right side of the heart through the right bundle branch, and also to the left bundle branch, which bifurcates into the left posterior fascicular and also the left anterior, all the way down the Purkinje fibers. So in bundle branch blocks, imagine if there was a lesion or a block either on the right side of the ventricle. How would that ventricle depolarize? So you have to remember, characteristic of cardiac muscle cells, it has automaticity, it conducts electricity. Rather than traveling down, it's like thinking about a highway, you know, Ecuador Expressway. If there's a block anywhere, what would we do, right? We would find alternative routes to get to our destination. It's the same thing here. If there's a block either on the right bundle branch or the left bundle branch, the ventricle will still contract because that's the characteristic of cardiac muscle cells. It just won't contract as quickly as possible. The wave of excitation would travel through the other side just to get back to that side of the heart rather than just traveling down the freeway. It would take, different routes to get there. Okay, so in a left bundle branch block, the QRS duration, remember when they both contract at the same time, we agreed that the QRS interval is 0.8, 0.8 to 0.12, right? So that's the normal. Here it would be greater than 0.12 because think about it, they're not contracting at the same time. Either the right contracts first and then the left contracts second. But since both of them represent the QRS complex, it will be wider. And that width is the time it takes for it to contract. So basically, just like I talked about amplitude, contraction being measured as amplitude, now it's contraction being measured over time, right? So when our QRS is greater than 12 seconds, we know the ventricles are not contracting at the same time. One is contracting before the other. And then this is how we can tell, is it a left bundle or a right bundle branch block? So usually the QRS duration is greater than 0.12. And then the terminal R wave, there's a terminal R wave or RSR in lead 1, AVL, and V6. Another cheat way is the EKG will tell you. For the right bundle, same deal. The left is contracting first, and since there's a block on the right side, the left would contract first, and then the wave of excitation would travel all the way around the blockage to the right side. So QRS complex is greater than 0.12, terminal R wave, and RSR prime in lead V1. So I can actually show you here a little better, how this happens. Think about that anatomical page I showed earlier. The AV node is somewhere here in the septum. And also, I've mentioned this about vectors, right? If the wave of excitation is going towards a positive, it's an upward deflection. If it's going away, it's a negative. So for a left bundle branch block, that's this on the right, right? It's blocked, so the RV, the right ventricle, is going to conduct first, and then the impulse will travel through the right to the left. So first, it goes from 1 to 2. It looks like it's a positive deflection first because we're going towards the positive. And now it has to travel all the way around the negative before it gets back to the left ventricle. So that gives us a significant negative deflection. On the other hand, for the right bundle branch block, the wave of excitation moves away from the right side because the left side is conducted first. So when the left side is conducted first, it's a negative deflection from the isoelectric line. and then it works its way towards the positive. So if you think about it, left bundle, big negative deflection, right bundle, big positive deflection. So I've actually come up with sort of a sneaky way to remember which is which. The end of the R wave where it meets the ST segment is called the J point. So if you draw a line across the isoelectric line under the QRS complex, either for the right or the left, it gives you what looks like a triangle, right? So if you want to identify if this is a left bundle or a right bundle, all you have to do is look at lead V1, only lead V1. And I don't know how many of us drive here, but if you look at lead V1 and your QRS complex is greater than 0.12, if the big deflection is positive, it's a right bundle, just like you would push up your turn signal in your car upwards towards the right. If the big area of deflection is negative and your QRS complex is greater than 0.12, it's a left bundle branch block. And just like you would turn your pointer, you know, your turn signal to the left, that's a left bundle branch block. So that's sort of a cheat way to think about it. So remember, it has to be a QRS greater than 0.12. And so these are the different morphologies. These are different ways it would look like on a 12 lead EKG. So it may not look just the same way. The most common would be QR at the bottom, but it could look any of these ways, okay? All right, so I'm going to talk about some other conduction analyses or conduction abnormalities, right? So first, I'm going to talk about the first degree AV block. And this is basically a pathological delay in the AV conduction. Okay, so if you actually look at this, there is a P wave before each QRS complex for each of these complexes. The only difference is the PR interval is greater than 0.20. So remember, in terms of the intervals, it should be 0.12 to 0.20. So here, there's a P wave before each QRS complex. It's identical. The R to R is also identical. So it looks like a normal sinus rhythm. But if the PR interval is greater than 0.20, this is a first degree AV block. All right. And the rhythm could be regular. So some of the causes include in atrioventricular disease, enhanced vagal tone, and acute MI, right? And this could be from an RCA cause affecting nodal function, electrolyte imbalances, or drugs. Second degree AV block actually gives people a significantly hard time because this can be a little confusing. So if you think about first degree AV block, there's a P, there's a QRS complex for each one. You never lose either a P, you never lose a QRS complex. Second degree also has two different types. There's a Mobitz type 1 and there's a Mobitz type 2. So for the Mobitz type 1, it's sinus rhythm. So you would start with sinus rhythm. Say for type 1, it's sinus rhythm with a first degree AV block because the PR interval is greater than 0.12. For second degree, it's sinus rhythm with an increasingly prolonged PRS interval until you lose a QRS. So the PRS interval starts this way. The next complex, it's longer. The next one, it's longer, and then you drop a QRS. So if you take a look at this diagram up top, look at the first P in QRS. Look at the distance, the PR interval. Look at the second one, the PR interval has lengthened. If you look at the third one, the P is almost in the T wave. And then if you look at the next one, we've dropped a QRS complex. And then it starts all over again. So the last PR interval looks like the first. So it's almost like at every third beat, it will drop a complex. So that's second degree type 1. So for Mobitz type 2, sometimes this is actually easier to identify. the PR interval is actually constant. It's constant throughout. There's a sinus rhythm with a constant PR interval until you drop a QRS. So constant, constant drop, constant, constant, constant drop, constant, constant, constant drop. You know, so what causes this are inflammatory disease, cardiac tumors, trauma. Believe it or not, many of us are walking around with either type 1 or type 2 blocks, and we're completely asymptomatic. The concern is that these may progress, and they may progress to type 3 block, and this is a complete heart block. So a complete heart block is when the atria and the ventricles are divorced. You know, the atria is doing its own thing, the ventricles are doing their own thing, and that just means there's a disconnection between the Cyanoatrial node and the atrioventricular node. So if you look at this diagram, the SA node is working properly, it's firing. So the P waves are even. They're even throughout. So the SA node is firing, the atria are contracting, but that signal is not getting to the AV so they could be evenly matched. So the AV node is doing its own thing. So if you look at the R to R, they're also constant. They're just not in sync. So this is complete heart block. And this is a significant medical event. True story. I had I think it was a 90-year-old patient in the ER once who came in with shortness of breath and chest pain. So we put him on, you know, we did a chest x-ray, we did an EKG, and he had complete heart block. And his wife, who was, I think, 80-something, was there with him. And while she was there, she got lightheaded. She was a little dizzy. So we got an EKG on her, and she was also in complete heart block. You know, so it's kind of interesting. So these could be congenital, it could be caused by drugs or an MI, and in these patients, they need a pacemaker. And the pacemaker basically now just puts everything back in sync. So PQRS, and they can march together. So some other things that we see on EKG are atrial enlargement. So imagine if the atria is too large, you know, it's dilated because the patient has, you know, some sort of ventricular issue. This is demonstrated by a P wave that's 2.5 millimeters or greater. So when the atria is larger, remember the atria is smaller because their only job is to feed the ventricles. So, but when they get larger and larger, we're talking about contractility and measurement of amplitude on an EKG. So if you see a high amplitude for a P wave, it means the atrium is larger, right? So it's contracting harder because, you know, it has more muscle mass. So some of the causes include lung disease, tricuspid disease, or just right ventricular function issues. So that's for right atrial enlargement. For left atrial enlargement, we actually see this as a biphasic P wave, right? Or like a double hump on the P wave. And this is usually longer than 0.11 millisecond, which just means rather than both atria conducting at the same time, they're conducting individually because the left is not getting enough time to contract. So those humps are like representative of left and right conducting almost separately. All right, and the pathology with this would just be left ventricular issues, because when you have left ventricular problems, it backs up into the atria, right? Either left or right. So whatever issues you have in the ventricles, it'll force its way back into the atrium. Ventricular hypertrophy. So if you think about the ventricles and the role of the ventricles, or the right side is to pump blood into the pulmonary circulation, the left side is to pump blood into the central circulation. What's the problem with having thicker, bigger ventricles? That just means you'll pump more blood, better, right? No. The issue with that is when you have thicker ventricular walls, it decreases the size of the chamber. When it decreases the size of the chamber, it decreases the amount of blood that fills into that chamber. It also decreases the amount of blood you eject. And once that volume decreases, there's a decrease in cardiac output, which is how you perfuse your body. So that's a significant issue. So some of the causes for right ventricular hypertrophy include some pulmonary hypertension and just typically just pulmonary issues, because the right ventricle pumps blood into the lungs, into the pulmonary system. And for right ventricular hypertrophy, so think about it. If the right ventricle is very thick, it's going to contract very hard. And if it does, it's going to have a higher amplitude on EKG, because remember, it's conduction translated into amplitude on a piece of paper. So if you look at this, tall R waves and the RV leads, you can see how tall these are, the Qrs complexes are. I mean, just looking at the EKG, they would look abnormally tall. So that's a right ventricular hypertrophy. For the left ventricle, same thing. Too thick, you decrease the chamber size, you decrease ejection fraction, ventricular filling time. And this now, I mean, has more symptoms or issues with central circulation, because you're not getting enough blood to the rest of the body. And this is what it would look like. So once again, taller QRS amplitude in the left ventricular leads, okay? The LV leads are 1, ABL, 5, and 6, right? So tall amplitudes in the ventricular leads. So prolonged QT. So for men, remember 450, women 460. The corrected, so the EKG would actually calculate your QT corrected. And if this is prolonged, we should look at drugs, mostly hypocalcemia, hypomagnesemia. Basically, electrolyte imbalances cause this when patients are cold, when they've experienced an MI, it could be congenital, or if they have increased intracranial pressure, that would do this too, okay? So if you remember back to our case study, a 45-year-old woman who came in with chest pain, if we were to look at her EKG once again, we see ST elevation in 2, 3, and ABF. And this it's an inferior wall MI, you know, and that's how we would interpret this, and we would treat that accordingly, okay? I also like to finish with objectives as to why, or exactly what we covered. So these were our objectives. We talked about the anatomy, we talked about coronary arteries, we talked about electrical views, we talked about measurements and waveform interpretation, we talked about QRS axis, we talked about these different rhythm analysis. And as I mentioned earlier, we can make practice ECGs available to you upon request. So that concludes my presentation. I have some references to, you know, I didn't come up with all this information, and it's very prudent to give credit to my resources. So I'm happy to take questions at this time. Questions, thoughts, concerns, you know, recommendations.
All right, so just like before, you can either raise your hand to ask directly or put a question in the chat. And while we're doing that, I'd just like to say that that presentation was wonderful. I felt like I was back in the lecture hall in university, you know, getting all this information, you know, interacting. And a reminder, this will be available to everyone who, you know, requests for a certificate of participation. You will get the lecture notes, the recorded presentation, as well as the slides. So I do see one question here from Kenny Napier. It says, how can we prevent and diagnose a heart block?
Okay, so that's a good question. Unfortunately, there's no way to prevent a heart block. You know, it's an intrinsic thing that occurs. It could either occur on its own, or it can occur because of an MI. You know, so, but how can we diagnose it? We can diagnose it on EKG, you know, basically. And some of the symptoms include lightheadedness, you know, or patients that have an acute MI will present with a heart block. And also, this is probably a good plug. We'll be doing this monthly, and just based on some of the occurrences in society, I think our next presentation would likely be cardiopulmonary resuscitation or basic life support. But these are the types of skills that we hope we never need, but if we're ever presented with those situations, it would be nice to know exactly what to do, so oh, that's our partner giving us a shout out, but thank you very much. Once again, if you have any questions, if you think of anything, okay, I think Mr. Abubakar has his name up again. Oh, his hand up.
Yeah. So, sir, as it is known that exercise has good, it enhances the heart, generally the contractility and all. So in a case where there is one of these arrhythmias, either due to infarction or whatever, does exercise helps or it worsens the condition of the heart in those conditions?
So that's a good question. So I know some of us here have people that go jogging and they drop dead. And we wonder because we're like, well, exercise should improve your health. So why would this occur? I think in the absence of cardiac pathology, exercise is very helpful. Exercise, helps you decrease the likelihood of coronary artery disease. It decreases hyperlipidemia. It improves hypertension. For those who have diabetes, it helps with managing that. It helps with managing your weight. But imagine the fight or flight response, right? If we have a lesion that's causing ischemia, so there's a blockage already and the heart is not getting enough blood. Now, if you stress the heart by going running, remember fight or flight, you actually divert blood from organs of the body that don't necessarily need the blood at that time to your brain, your heart, and your lungs. So now you're going to require twice as much work from the heart. It's only going to enhance those areas of ischemia when you exercise. And so it could actually cause a heart attack. So I mean, I'm not trying to scare us or stop us from exercising, but in the presence, or if you're aware that you have coronary artery disease or any cardiac disease, then the recommendation is to either see your practitioner before you exercise and understand how much exercise you can have, but outside of that, exercise is actually very helpful.
Thank you so much for that answer, Dr. Akintade. Do we have any other questions, comments, concerns before we close out? We're just about at
giving some
close to the 2 hours.
To some of my alumni members from Federal Government College Idani, Mrs. Ifoma Babatunde, Kenny Napier, thank you guys for being here. And Ms. Mutia Ipaya from Reliance, one of our organizational partners. It's nice to have you here to support. Once again, the goal of this presentation as Health for Nigeria, as our name indicates, I think we have a powerful name, which means we have a responsibility to Nigerians as a whole, but more to even healthcare professionals in Nigeria. And, the more we're able to provide these opportunities to learn, something in these types of fora, then the better. So it is my goal to use to leverage on my personal and professional networks to bring professionals to come talk to us about some of these different topics that could either help day to day or help us in our clinical practice, for those who practice clinically. So thank you very much for your time and attention. And once again, if you don't have any questions now, if you want to reach out with questions or if you have other ideas, please let us know. Okay, so Kenny Napier is asking if we would advise if we see a doctor before doing any exercise. My recommendation is I don't believe that is necessary if you don't have any history, a documented cardiac history. But if you do, then you should speak with your doctor first. And technically, I mean, this is advice for anyone. We should undergo annual physical examinations every year. And that might be a way, to catch ongoing cardiac issues if they're present. And then that way your doctor can help you out or make positive recommendations. But if you don't have any history, I don't recommend doing that. What I would recommend is having a checkup at least once a year. And over the age of 40, for some of us that are older than 40, when you go for your annual checkup, ask for an EKG just to make sure your heart is doing well.
Thank you so much, sir. All right, so before we close, I would just like to give a short presentation, providing a little bit of information about what's available to everybody here. So basically, to obtain your certificate of participation for this lecture, you will get the lecture resources, that's the recording, the slideshows, and any supplementary materials that Professor Akintade will be willing to provide. We have a small token cost of 5,000 Naira. Again, that's just to help us process this together and make it available to you, and also assist us in being able to do this more often. So this is available to everybody here. However, our nurses who are already working on our programs and any volunteers we have would actually be able to access these for free. And obviously you have to have been a volunteer before the lecture. So, in any upcoming lectures, any volunteers or any of our Health for Nigerian nurses, we don't have to pay the price for the participation, and we'll also receive all the resources as well. Here's our payment information to our bank in Fidelity Bank, our account in Fidelity Bank. And then you can just send your proof of payment to either myself or to Mr. Olumide Obe, who is also on this call, and we will get your certificate as well as the lecture materials over to you. Once you've done the payment, please allow us about 48 hours to put everything together and send it to you. And going back to what I said earlier, volunteers, anybody working with us directly has access to all of this for free. So where we have an opportunity for people to volunteer, we're looking for nurses, healthcare providers, public health professionals, anybody really interested in joining our program and supporting the work we do. You have opportunities to join us, access to all our lectures and webinars, industry experience, just to understand how things actually work out on the ground. And we're also working to have a mentorship program which provides guidance, professional experience, as well as just general connectivity with professionals who are far along in their career within the Nigerian diaspora. So, if you're interested in any of that, feel free to reach out to us on our website, type in your information, and you should get a response within, again, about 48 hours or so. And once any opportunities are available for volunteering, we will let you know. Any other questions or queries, again, feel free to reach out to myself at aoshaw@healthfornigeria.org or to Mr. Olumide Obe at oifedayo@healthfornigeria.org as well. And obviously, please follow us on social media. We post updates all the time on Facebook, Instagram, Twitter, LinkedIn, all over the place. So please follow us there and just to stay up to date on things we're doing. And thank you so much again. And I'll allow Mr. Olumide Obe to take over and give us a closing remark. All this information here, I'm sure you might not be able to get to all of it, but it will be sent to an email. As long as you registered for this lecture with your email address, we will send you all the information regarding the payments, regarding volunteering and all of that. So please look out for that within the next day or two. Thank you again. And Mr. Olumide, please take it away with the closing.
All right, thank you so much, everyone. So to start with, I would like to appreciate a highly esteemed Professor Akintade, our founder, for the wonderful and educative lecture. He's been able to dissect and do a lot of experiments on the lecture, and we are really grateful, sir. Once again, permit me to recognize someone here and that's the person of Dr. Oluseyi Adejumo. He's a senior lecturer and the head of department of the internal medicine department at the University of Medical Sciences, as well as the University of Medical Sciences Teaching Hospital. You are so welcome, sir. Thank you for joining us. Then all members too, like I may not be able to mention names and all. Thank you so much for joining us. I'm sure you've seen and you've had a lot in the lecture and all, and I'm so sure that you'll follow us through. So like the lecturer said, we'll be having this lecture like frequently. So the next series will be coming up soon, and we'll definitely send you emails and information about the next lecture. And also we'll be keeping your emails in our database, so we'll remind you of the lectures as time goes on. And just like the presentation of Mr. Osho on the details of to get your certificates and the lecture video, the presentation videos, and as well as the lecture slide and all, and also the token attached to it. I'm sure you all know that the lecture is way more than the token. So, but this is just for you to at least support the cause, and at the same time, like, just say this is something that is worth paying for, even though it's not enough to, like, we can't quantify the lecture. So once again, I say thank you so much, and hopefully we see you next month, hopefully. Thank you so much. And thank you once again to the team, Mr. Osho, Karina, I see you, Ms. Tolu. Thank you so much, everyone. Thank you so much once again, Professor Akintade. Really appreciate you. Thank you, sir.
All right, thank you, everyone.
So Olumide, I didn't realize Dr. Adejuma was here.
I saw him saying, I was like, this is Dr. Adejuma.
I think he's still on. Doc, it's nice
Yes, sir.
to see you. I think he's muted. And Mr. Abubakar, man, you are my hero. You know, you asked a lot of very pertinent questions. Thanks for that.
All right, thank you everybody once again. I just wanted to play that video one more time. So have a good afternoon or good morning if you're still in the morning wherever you are, and take care.